Yep, we can hear you.
We can hear you.
Great. Okay, let me start sharing. Okay, can everybody see the slides?
Yes, yes.
Yes.
Okay. Sorry, let me stop sharing, share my video, and then I will share. Okay, can you see me as well?
No, we just see a black screen.
Sorry, I think I've covered it.
There you go.
Can you see me now?
Yes, yes.
Great. So, okay. So, Melissa, should I proceed or should I wait a bit more? Oh, I think we are not even 5. Let me wait a bit.
I think we can wait a couple of minutes if that's all right.
Sounds good. What time do you think we should start? Like on the clock or give it a like couple minutes? What do you?
You could start right away at 5.
Okay, sounds good.
I think you should give few minutes, but some
Yeah.
people need to get in.
Sounds good. Let me then give like maybe at least 3 minutes. Would that be good?
Yeah, I think that's good.
Sounds good. Okay, so Melissa, should we start?
Yeah, I think that sounds good.
Very good. Hi, everybody. I am Dr. Kamgar. I'm one of the medical oncologists at the Medical College of Wisconsin and Friday. And I will be talking to you today about the pancreatic cancer, the biology, diagnosis, and treatment. If at any time you have any question, you can always interrupt me. We will also have a session in the end for questions and answers, whichever you prefer. So this is the outline of my presentation. Basically, discussion of some basics of pancreatic cancer. Why does it develop? How does it happen? Who gets it? What are the most common symptoms associated with it? And also, how do we make the diagnosis of this cancer? And then we discussed briefly about different treatment options for this. We discussed briefly some of the clinical trials that we have at Frederick Medical College. And then there will be, as we discussed, the Q&A section by the end of this talk. So talking about the basics of the pancreatic cancer. So what is the pancreas? It is a gland that is located very deeply in your abdomen, back of the stomach. Hard to examine it. A lot of times that's why, unlike cancers such as breast cancer, that is good, accessible, has good accessibility with exams. Unfortunately for this one, we don't have that availability. It has two main portions to it, which determines the functions of it. First is the endocrine portion of that. They call it the endocrine portion is the portion of the pancreas that basically is secreting the hormones. The most important one of them probably is the insulin, is one of the hormones that this section of the pancreas produces. There is an exocrine aspect or part of the pancreas that does produce the enzymes, and those are the enzymes that are important for digesting the food, namely the lipase, which is very important for digesting the fat in the food. And in general, to summarize the function, the main two functions of pancreas is to control the blood glucose. So if it doesn't work, people can get diabetes. It is also important to control and digest the fat in the food. And if people don't have digestion of the fat in the food, they can lose weight, they can have diarrhea, gas, and other symptoms associated with that. So what is cancer and what is normal? So in general, cancer develops when something happens that the cells in the pancreas start to grow out of control and they survive more than what they should. And also, in the process of cancer development, these cells in the pancreas can also start to behave differently. They can start to learn to spread out of the pancreas. They can go through the bloodstream, lymph, and what we call metastasis, and spread through the body and grow elsewhere in the body. So, why does this cancer develop? Think of your body as a building, and the blocks that make that, the building block of their body, they are called cells. Each of these cells, they have a center, a command center, which is the nucleus of the cell. And this contains a book that include all the orders, the do's and the not to do's for that specific cell. And this book of orders, which is the DNA, is structured in some chapters. Those chapters are the genes. Each chapter or each gene normally dictates a certain function. And then for the cells, in order to survive and such, they would need this DNA to preserve its integrity. And as the cells become old and die, normally they have to make sure a copy of this DNA is made and handed over to the next cell. And it's important for the integrity of that to be kept as well. So we have a huge machinery of spell checkers to make sure every time that a copy of this book is made, mutations or misspelling do not happen. So cancer develops because in the process of the mother cells giving birth to the daughter cell, one of these genes or some of these genes in some chapters, they can be misspellings, and that leads to error in the orders that are given to the next cell. And what that means is that these cells start to act and do things that they are not supposed to do. Most of the times, these faulty genes are in two categories. There are their genes that were supposed to control the growth. The misspelling makes it active all the time. So it's like pressing a gas pedal. It's just these cells are growing out of control without really the limitations in the lifespan that should be on each cell, without the limitation in how many cells can they give birth in their lifespan. So they start to basically live out of control and grow out of control. And also, sometimes this happens because spell checkers are having issues. So as these cells are dividing, the spell checkers are not working, and every time they're giving birth to more and more misspellings or mutations. How do these misspelling happen? Mostly in the context of two scenarios. It's either you might have inherited the first misspelling. Mostly those misspellings are in the spell checkers. That means that from one of your parents, you have inherited genes that are somewhat lacking in checking the DNA integrity when the cells are dividing. And because of that, in your lifespan, you're at high risk of making cancer because in general, your cells are making more mistakes over time. Sometimes also you acquire that, meaning that when you're born, the genes are fine, but over time there are misspelling that happen. And a lot of time there are factors in the environment, such as smoking, obesity, heavy alcohol use. These are things that can also increase the chance that, or increase the number of times that the errors happen in the DNA in someone's lifetime. So, there are two different types of cancer of the pancreas that can develop. The cancer of the endocrine or hormone-producing aspect, that is called the neuroendocrine. We are not talking about that. That is a less common, like about 7% of the tumors of the pancreas are the neuroendocrine. The most common cancer of the pancreas is the cancer of the exocrine cells, or the cells that produce the enzyme, and that is called the adenocarcinoma. That's about 93% of the cancers, and that is the subset of cancers that we will be covering today. So in whom do we see pancreatic cancer? Who develops pancreatic cancer? It is mostly seen in elderly. So the average age of patients with this diagnosis is 65. For sure, there will be more, like range more and less. And recently we are having a new spike in younger patients getting this cancer, not necessarily always because of hereditary condition, probably due to environmental factors that are not completely yet understood to us. In general, it is more common in the Black patients, in African American patients, and smoking can account for up to 1/3, 1/4, or 1/3 of the cases. Obesity is a risk factor, and then there are cases that this cancer can run in the family. Sometimes it's what we discussed, the hereditary, meaning that there is a certain gene that is inherited, and that single gene increases the risk. There are scenarios that they are familial, meaning that there are many patients with pancreatic cancer reported, but when we check for a single gene, we don't find that. It might be that there are a combination of many genes that predispose that family, and that we are not having a full understanding of that. So having a family number of patients with pancreatic cancer, even if we don't find anything in the genetic test, it's still a risk factor to be having more risk of having pancreatic cancer in your lifetime. And how frequent is this cancer? In general, it is not the most common. Like the updated, are about 3% of patients have that, but 8-point-something% of the cancers or deaths in the US happen because of this. And the 5-year mortality, you see, it was previously 10%. It is now about 12.8%. So I kept it to show that there are some changes since 2022 up to 2024 and such. There are improvements in the survival, but still the 5-year survival with all stages taken together remains still less than 13%. So how does this cancer present? In general, there are two major scenarios that if it's seen, patients should be really evaluated for pancreatic cancer. One is if you have an unexpected weight loss in somebody more than 60, specifically if they have any of these other symptoms, like if you have weight loss accompanied by back pain, new back pain, or new abdominal pain, nausea, vomiting, new constipation, diarrhea, or new onset diabetes. Specifically, the combination of weight loss and diabetes is a very high risk feature for pancreatic cancer. And for primary care doctors see that, they should really evaluate our patients with imagings for the pancreatic cancer. The other is that if somebody above the age of 40 develops jaundice, that's the other reason that they should be evaluated. For sure, like gallbladder stones and such can cause that, but we always have to be sure that there's nothing else accounting for that. So how do we diagnose pancreatic cancer? So the major imaging that we do, basically what it means is that if somebody has symptoms suggesting that they might have cancer, the first thing to do is to do an imaging. And the first imaging that we do is the CT scan or CAT scan. As you see, it gives us a good image, and this would be the pancreas and the area that I have marked. This is showing a tumor or a mass in the pancreas. So using the CT scan, we can identify it, but this is not enough to make the exact diagnosis. We would need to, most of the times, utilize a means of getting biopsy in cases that it is not spread out. The doctors go in with an endoscope, they use an ultrasound, they put a needle into the pancreas, and then that tissue is evaluated by the pathologist under the microscope, and that is when they make the actual diagnosis and the actual subtype of pancreatic cancer diagnosis. So how is this cancer stage? What are the different staging of it? So one way to look at it is it's either metastatic, meaning stage 4 or spread out, cancer that has spread out of the original organ or not. And in cases that it is not, it's not only the matter of the size of the tumor, but also it's important to see how it is in relationship to the other major organs and to the other major blood vessels. And that is how the surgeons, before doing or thinking about surgery, they really classify it into different categories. The earliest stage is the one that is the easiest theoretically to be to have surgery without any need for cutting or reconnecting major blood vessels or organs. This is the operable stage. This is when the pancreatic tumor is really located just in the pancreas and it has not started to involve any blood vessels or any other organs around. And then there are different stages of how much locally it advances. It can be earlier stages, meaning that it's touching blood vessels. And if it's surrounding blood vessels, there are blood vessels that can be cut and reconnected. And then there are some times that it has advanced so much that it has involved major blood vessels that it's not compatible with life to cut those. And that means that this is really a stage that cannot be taken out with surgery, because either it's very risky and the surgery will be really high risk for bad things happening throughout the surgery, or it's a surgery that we don't think will be leading to the cancer completely taken out, which is basically unsuccessful surgery. If a surgery is done and the cancer is left behind, that means that this surgery is not curable, and this surgery is going to just give our patients side effects of surgery without the cure that we are hoping for. And for sure, if the cancer is visibly out and spread out of the pancreas, that is when it is the metastatic disease that doing local measures such as operation or such will not be helpful. And these cases should be treated with more treatments or therapies that really detect the cancer wherever in the body it is, and they try to eradicate this, what we call the systemic therapy. So in the case of metastatic cancer, how does metastasis happen? So in general, pancreas is full of blood vessels and full of the lymph vessels. Normally, it is through the invasion of the cancer into these blood vessels, going through the lymph, and a lot of times mostly through the bloodstream, that the cancer cells start to spread out, and then they start to they seed in other organs, and then they can start to grow elsewhere in the body. For pancreatic cancer, the major areas of metastasis, it can be liver, it can be lung, and it can be peritoneum. Peritoneum is a very thin layer that is basically, if this is all the organs in your abdomen, there's one layer that attaches to the abdominal surface that makes this completely a separate section as opposed to the outside. And there's another section of peritoneum that really is covering the organs like intestines and such. These are the areas that the cancer cells, sometimes through bloodstream or sometimes through dropping down from the pancreas, they can start growing. So this is a third common area that the pancreatic cancer can spread to and grow. So what are these stages in terms of the time that our patients present with the cancer? What are the stages at presentation? Unfortunately, majority of cases, it is already at a stage 4 or metastatic disease when we find it. Reasoning is because, again, as we discussed, it's not an organ that is easy to do examination on it. The symptoms of it can be very vague, and it can't really be masked for many reasons. It can be attributed to other things, and by the time that the evaluation is done, it can get to the advanced stage. We don't have a good screening tool for it yet. And even in the scenarios that we pick it up very early stage, meaning that we think that it's really localized to the pancreas by the time that we pick it up on imaging, as you can see that less than half of our patients survive up to 5 years, meaning that even in that stage, this cancer has a tendency to spread out early on without us seeing it. So it's considered a systemic disease from the initial diagnosis in majority of cases because of this fact. And what are the treatment modalities that we have for it? If the cancer is local, we can utilize local treatments for it, and that include the surgery, meaning cutting the cancer out, and then radiation, which is using high beam of energy to treat the cancer. And the other is systemic treatment. These are drugs that are given either by oral or by vein. They spread throughout the whole body, and they try to eradicate the cancer wherever it is. And there are different types of systemic therapy. We will discuss it in a bit more detail later. We have chemotherapy, we have immunotherapy, and we have targeted therapy. What is radiotherapy? So basically what it means is that the radiation oncologist is the doctor that does this modality of treatment. They will be using machines. They're trying to target radiation, which is high energy, different versions. They can be different technologies for radiation. But the whole idea is to giving high energy to the certain local area where we think the cancer is located. And the whole idea is to try to damage the cells, mostly the DNA of the cells, beyond repair, so that then we are hoping that this will lead to the cancer cells dying. This modality is very important, who gives it and what machine they use, because truly identifying a personalized plan, trying to make sure that the radiation is focused on the cancer, trying to preserve the normal organs around it, that needs a lot of expertise, and that needs the right techniques and machines. So it's very important when you're getting radiation to get it in a center that has excellence for pancreatic cancer care, that had the right providers and the right machines for that. What is surgery? So these are basically different operations that surgeons use them to remove the pancreatic cancer. As we discussed previously, a successful surgery is truly a surgery that can that can take the cancer all out without leaving anything visible behind. And there are different types of surgery for pancreatic cancer, like what is called the Whipple surgery. It's mostly when the tumors are in the head or body of pancreas. It includes resection of parts of the bile system, gallbladder, small intestine, pancreas. It can be more of a what we call the distal, which is resection of the tail of the pancreas, spleen. And it can be a combination of like taking the whole pancreas out. So there are different modalities of taking the cancer out, and the person who decides which type of operation is right for you, it's the surgeon. Similar to radiation, when it comes to surgery, it is very important to get it in a center that have experience with pancreatic cancer, and they do certain number of surgeries per year, because first of all, the success of surgery is more, and second, the complications is less, the care throughout around the time of surgery is much better. So that is why I would say for sure, having a good oncologist is important, but I would say getting an expert in radiation oncology and surgery is even more important. And this is worthwhile traveling sometimes outside to make sure you are in the center with that excellence. What is chemotherapy? These are drugs. As we discussed, they can be given by mouth, like there are pills that sometimes you take, but majority of the chemotherapies are drugs that are given through the vein, a lot of time through the portacat. How do they work? These are designed to prevent cells from giving birth to new cells. Majority of the time, we discussed about for the cells to give birth to new cells, they need to make a copy of the DNA. Majority of them are designed to prevent that copy machine from working, meaning that they're just messing up with the machine, preventing the cells from making new DNA and preventing that way from new cells to be made. There are also some other chemo drugs that are designed in a way that prevent the already made DNA to be handed over to the next cell. So most these chemotherapies are designed to basically prevent cells from giving birth to new cells. It is good because as the cancer is growing, and that's the nature of it, it can respond to these drugs. It is bad because it can also affect your normal cells, because it's not just specific to cancer cells. It can affect the division of normal cells. And that is why the side effects of the chemotherapy drugs can happen. So there are different types of chemotherapy regimens, and they can be a 3-drug combination regimen, 2-drug combination regimen, 1-drug regimen. Majority of the time, because of the fact that the responses and the shrinkage to the 1 drug only is not great, normally we try not to use just 1 drug. But whether to use 2-drug or 3-drug, whether one might be better than the other, that is something that your oncologist will decide, and we will discuss about how that is done. In general, however, the 3 drugs in a whole population might have better chances of shrinkage or less growth. However, they are also associated with more side effects. And there are specific subtypes of pancreatic cancer that actually do respond better to this drug combination regimen. So it's a combination of the tumor biology and how our patients are feeling, or what baseline characteristics that they have that make us choose one treatment over the other. So how do we decide in between surgery, radiation, chemotherapy? How do we decide the order of the treatments? So we discuss all of our newly diagnosed, specifically non-metastatic cancers. We discuss it in our tumor board. It's a weekly tumor board that all of our pancreas experts, a large group of teams, including radiation oncology, medical oncology, radiologists, pathologists, GI doctors, nutritionists, genetic counselors, and such, they are all part of this tumor board. And we discuss our cases one by one, and we try to find the best modality or best approach for each of our patients. Assuming that we are not having a really rare scenario that we should not proceed with one measure or another, mostly because of the high risk of what we call micrometastasis, which is early spread of cancer, which is not detectable by a scan, we normally try to use the approach of chemotherapy first, trying to eradicate as much as cancer as possible locally and systemically. then radiation therapy, trying to eradicate the tumor locally as much as possible, and then it will be surgery. This is a modality that might take about 6 to 7 months, the combination of chemo and chemoradiation, until we reach the point of surgery, hoping that we increase the chance that we can provide cure to our patients. In the metastatic setting, however, majority of the times we can't use radiation or we can't use surgery, except for when there are really local mechanical issues that we have to deal with. And mostly the treatment includes systemic therapy, most of the times chemotherapy, and in some scenarios, immunotherapy, targeted therapy, and we'll cover that later. So how do we choose one chemotherapy over the other? Again, as we discussed, it's a decision that your medical oncologists make. Part of it depends on how healthy you are. What are the baseline issues that you're dealing with? Let's say you have a bad underlying nerve issue, you're having a lot of numbness, tingling. We might go for a chemotherapy that does not cause more numbness or tingling. Or you have bad diabetes, we might try one that allows for less increase in the blood sugar. Or there are different scenarios, or some people are really concerned about hair loss. We try to go with the chemotherapy that has less hair loss. Or someone might be a pianist. We are trying to preserve their nerves as much as possible. So there are many factors that are how healthy you are and what other factors we have to consider. And also on the tumor biology, because so far most of the choosing of the chemotherapy has been based on how the patient is, but now there are advances in the molecular evaluation of the tumor that is allowing us more and more to identify subsets of tumors that might respond better to one chemotherapy over the other. So it is expected that as our knowledge of molecular features of tumor expands, that will be also a major contributor to which chemotherapy drug we might choose over the other one. And then it is very important, like these chemotherapy drugs are standard, meaning that many of them are standard, FDA approved, the regimen is set, but it will be very important to follow closely with your doctors, because despite that, each individual is different than the other one. Each person might have different side effects than the other one, and they would need to adjust the chemotherapy per the tolerance and per the toxicities. So it's very important to be in touch with your doctor when symptoms happen, because they can adjust your treatment and you might still be having the same amount of response, but maybe with better tolerance. And also it's always important to deal with side effects and with toxicities early on, rather than waiting too much when it's too complicated and risky or life-threatening. So it's very important as you're in chemotherapy to be in touch with your doctors and ask them about potential adjustment that they can make in the treatments. So how do we evaluate response? When we are giving treatment, what is our goal? How are we monitoring whether it's working or not? So one is clinical response, meaning that, let's say you're presenting with pain or weight loss or decrease in appetite. If with the chemotherapy those get better, you're eating better, you're doing more, the pain is gone, that by itself means that it's a clinical response. And that evaluation is done every time that you go to clinic and your doctor sees you. For sure, that is for toxicity evaluation, but also they're trying to understand whether we are seeing any clinical response, or as opposed to its clinical progression or not. The other is what we call biochemical response. And by that, we are looking at different things in the blood that would be representative of the tumor load in the blood. If the tumor produces certain chemicals that we call tumor markers, such as CA19-9, CA125, CEA, those might be the ones that we will be monitoring. Also now with the availability of tumor DNA in the blood, that is also another means that we could follow over time to understand the extent of disease, whether it's getting smaller or not, and the evolution of the cancer, whether it's changing on the treatments or not. And for sure, we would need eventually the CT scan to measure the disease, how it was before we started chemotherapy, how it is after, is it getting smaller in size, is it stable, is it spreading to any new areas? So that is the evaluation that we do by serial CT scan, which is mostly done every 2 months. The reason for that is that unfortunately, in the metastatic setting, although the cancer might respond initially to the chemotherapy or to other treatments, it will eventually develop resistance. So that is why it's important for doctors to monitor the cancer over time and try to detect that when it happens to make sure a switch in the treatment can be made in a timely manner. So we discussed about different causes, and we discussed that there could be hereditary condition predisposing to pancreatic cancer. So for pancreas adenocarcinoma, up to 10 to 15% of cases could be hereditary, meaning that you could have inherited it and you could have also given it to people who are like your kids and that are related by blood. The way to check that, it's to check your normal cells. We have to obtain some normal cells, and that is either by the swab of the mouth or it is by blood collection. We draw the blood or saliva and we try to find normal cells. We try to check the DNA of your normal cells for certain genes and mutations. And if you find any, then that means that in this specific person, it is hereditary, and that is when other family members needs to be checked. But if we do these tests and it's negative, then we don't recommend testing in others because the person with the cancer, we couldn't find it in them. So there's nothing specific or special to look for in other family members in this scenario. So why do we recommend the genetic testing? So for sure, partly is because of the hereditary condition. It runs in the family, so other family members can get found. Many of these mutations or genetic mutations are not just predisposing to one cancer, they might predispose to different types of cancer. And many of those cancers might have good screenings like breast cancer, ovarian cancer, prostate cancer, which will be important to check for them, do earlier screening, or sometimes start in high-risk programs or prevention modalities for the cancers. The other is that also if you find certain changes or certain hereditary condition, that can also affect the treatment that we give to our patients. As an example, in the context of BRCA mutation, there is a certain drug, an oral drug, PARP inhibitor, as an example, olaparib. That's a pill that our patient can take by mouth, and that is something that works in patients with BRCA mutation, but not in patients who do not have that. Or, for example, they have certain of patients, they have a mismatch repair deficiency or Lynch syndrome. We might be able to already use the immunotherapies that are FDA approved otherwise to treat the cancer, and it can provide very good control of the tumor. So what is targeted therapy? So there are scenarios that the tumor is truly produced by a certain mutation, which turns a switch on. Sorry. And then we have drugs that can turn that switch off. So this is basically the targeted therapy, finding that specific target and using a medication that can act against that target. What is immunotherapy? So in general, each of us might produce cancer cells in our body every day. Mostly our immune system is trained to identify those cells as abnormal cells, cancer cells, and eradicate them. A lot of them, for the cancer cell to evade the recognition by the immune system, it puts a mask on its surface so that when the immune cells are passing by, they see the normal, they don't see the cancer behind. Immunotherapies are in general designed by different means to remove this mask and to expose the cancer cells to the immune cells so that this way immune cell can recognize cancer as cancer and they can start fighting the cancer. So who qualifies in general for targeted therapy, immunotherapies? These are medications that more and more are becoming available. Part of it is because we are having better means of evaluating the tumor molecular aspects, DNA, RNA, trying to understand what is driving the tumor, what is the strength of tumor, and what is the weakness of the tumor. And then we can try to find, through this evaluation, specific treatments that might really be basically individualized treatments that we can find for each person for the unique feature of their cancer. And this test is done not on the normal cell, but on the cancer tissue, meaning that what we have to do is from the biopsy that is obtained, we send it to the companies that they run the tumor DNA and RNA. They give us a report of what is driving the tumor. Your oncologist will evaluate that, and then they will decide whether you would be a candidate for targeted therapy or immunotherapy or not. In terms of what we do in general, we do genetic tests universally, meaning that we try to do genetic tests for all of our patients. We try to do cancer DNA evaluation universally as well. And then there are certain scenarios here that we can use standard therapies, as we discussed. For example, there are a subset of patients which have like Lynch syndrome that we would be able to use immunotherapy. There will be 5 to 10% of patients that their tumor have certain features that we already have targeted therapy available that we can use for them. But we will see that more and more this aspect of cancer DNA evaluation is becoming more important because most of our treatments are moving to be more targeted or individualized based on features of the cancer. What is a clinical trial? So the way the drugs that we are utilizing now are used or were developed is that there was a standard available at a certain time, and there was an idea that a new drug will be better than that. So to test that, we have to go through the clinical trials. The idea of clinical trial is to establish whether a new treatment is safe and it's more effective than what we had previously. So all of the standard FDA-approved drugs, they have gone through this process of trials to be accepted and to be used in humans. So unfortunately, despite a lot of studies, the outcomes in pancreatic cancer still are not optimal. So we know that we can do much better on that. And the best and the safest ways to get to that level is to get involved in clinical trials so that you can have access to new drugs. Everybody understands the importance of timely and adequate treatment of pancreatic cancer. So none of the trials in pancreatic cancer are placebo, meaning that, everybody gets what is standard. And in some scenarios, we are trying to add medications to that to see whether that will be better than the standard. Or sometimes if there's truly no standard available, we are trying to use new drugs to see if we can provide new options to our patients. So I have presented some of our clinical trials that we have at MCW, and there's this link that you would be able to go to find different studies that we have. We have a very good portfolio of trials for pancreatic cancer. There are many different trials for the earlier stages, meaning that the stage that we are hoping to do to take the cancer out by surgery. Many of them are really like very, very novel treatments that will be practice changing. As an example, the pancreas study that we have, it's a study that is really trying to determine what chemotherapy we should pick based on the molecular features of our patients. The soft trial is using a very novel modality of radiation, the SBRT, and it's going to comparing it to the conventional radiation and see whether this will be safer or better in terms of use as opposed to the standard option. We have the study that is adding immunotherapy to radiation to see whether we will be able to obtain better responses. We also have post-surgery studies. We have the individualized targeted therapy in patients who are having resection of pancreas tumor, but they have high risk of feature. We call it Protect Panc trial. And also we have the KRAS vaccine study that is ongoing. It's a peptide vaccine for different KRAS mutations in the tumor. KRAS is the most common, like 95% of tumors in pancreatic cancer have it. So it's a very good target, and this study is going on at our center. We also have very novel studies for the metastatic setting. One example is the equivalent of Protect Panc, but it's in the metastatic setting. It's the profile-related individualized cancer therapy, meaning that The tumor will be evaluated comprehensively, and then it will be discussed in a molecular tumor board. And the doctors on that board will try to come up with the best combination therapy for your cancer with the features that it has. We have multiple immunotherapy studies. Examples are studies that are trying to use new ways of immunotherapy because the FDA-approved immunotherapies didn't work as well for pancreatic. So these are novel ways of activating the immune system. Two of the promising studies, one is the T-cell therapy that we have. These are studies that are trying to remove your own T-cells, engineer them, put them back in your body, basically turning your T-cell to super T-cells that would be able to potentially find the cancer and fight them. And we are in the process of opening a KRAS inhibitor. This is a very promising study. Despite presence of KRAS in the tumors, as we discussed, 95% of pancreatic cancer tumors have it. We have not had good KRAS, anti-KRAS drugs. And this is one of the most promising anti-KRAS drugs, which will be available to us soon in the setting that we have already done one chemotherapy. We are doing the second treatment, and we will be able to utilize this KRAS inhibitor, specific KRAS inhibitor. We also have the study that is looking at certain type of mutation, the MTAP deletion, and we have a pill that can be taken by mouth. So as you see, nearly all of our studies are focusing on features of the tumor, and that is why, as we discussed, doing molecular testing early on the tumor is becoming more and more important. This study is looking at mutations and protein expression. This one is expression of something called Claudin 18.2. This one, deletion of MTAP. This one, certain KRAS mutation on HLA typing or new makeup. This other one, presence of KRAS. So it's very important to have the tumor evaluation be done so that you would be potentially referred to these studies. So with that, I would want to conclude, and I would be happy to answer any questions if you have.
It looks like there's a couple questions in the chat. Let's see. I think you kind of answered the question about what is the difference between chemotherapy and immunotherapy during your presentation. One of the other questions was, do you know of any targeted therapies for a CHEK2 mutation?
So there are two different, I think we have potentially as part of the iPredict or Protect Panc and such, we can utilize different drugs. One is that we saw a certain type of, we saw that irinotecan-based chemo might work better on tumors, specifically germline CHEK2 mutations. So as long as this is a mutation that is not just random mutation in the blood, this is a mutation that is truly present in the tumor, and specifically if it's hereditary CHEK2 mutation, many of these tumors do better than average on irinotecan regimens, like, for example, FOLFIRI or liposomal irinotecan, Naliri. So that will be one option. There are for sure other targeted therapy options. There are other already available targeted therapies that some of them have some CHEK2 inhibition in them as them. There are some pills that potentially can do that. So I would say it's either standard utilizing a certain chemotherapy or going on some specific clinical trials that are addressing CHEK2. CHEK2 is a counterpart of another molecule called ATM. ATM and CHEK2 are spell checkers, meaning that they're important in making sure that your DNA, if it's damaged, they repair that damage. So the drugs that are used for this setting, they're basically trying to cause that certain damage on cancer cells because they know the cancer cells cannot overcome that. So that is why CHEK2 becomes a potential target for certain drugs. I think the others are there trials to prevent metastasis for Whipple surgery. Survivors for 4 years without recurrence of the cancer. I would say there are different scenarios. Let's say one is that you have been fine and something is happening, like tumor marker is going up, but we don't see the cancer yet on the imaging. there are studies, we have a study available, the Protect Panc would be like the individualized therapy in that setting can be used. For sure, if the vaccine studies show promise, if they show that we can really activate the immune system to fight the cancer, I would see that they can be utilized in such setting as well, meaning that we can try to see it now, if we can utilize it shortly after treatment as well, or maybe even later on if need be, to try to activate the immune system against the cancer cells. So the short answer is that not in somebody who is doing super well, more in the setting that we are concerned that things might be a bit getting out of control, but I can see that changing in the future. Is any cancerous cells left when having Whipple surgery? That is the challenge, that a lot of time we think that cancer cells can be left despite Whipple surgery. How do we identify it and how do we try to prevent it? So the idea of using chemoradiation and all of those is trying to eradicate those cells before surgery. Sometimes, however, there are features that make us believe that although we don't see anything on the imaging, that there might be leftover cancer cells, what we call it high-risk features. Like if there are many lymph nodes positive, if their margin of surgery is positive, if the tumor marker is not going back to normal, if we can find tumor DNA in the blood. That is when we suspect that there are cancer cells left behind. We can sometimes utilize chemo, but we have that Protect Panc study specifically for this setting, trying to use more newer drugs, targeted therapy, immunotherapy, trying to treat based on the features of the tumor, being a bit smarter and picking up our treatments. So that is the setting that we are trying to not wait until the cancer becomes metastatic, but try to do something to try to prevent that from happening. Can radiation therapy, oh, sorry, I missed something. Can radiation therapy harden a tumor and make it more difficult to remove during surgery? I think that's why how you get and where you get radiation becomes important. It's important for the radiation to be enough to eradicate the cancer locally as much as possible, but not too much to damage your organs or cause perforation or long-term toxicities. As long as it's done with the right technique, with the right dose, and as long as surgery is planned in a certain time span, normally that's not going to be a problem. And that is why I think it's very important for the radiation doctors and the surgeons to work as a team together to make sure that radiation does not interfere with surgery, but it improves the odds of surgery. And if given rightly, it can actually decrease the local complication like pancreas leakage, like the enzyme of the pancreas leaking and causing issues. So it can actually help with surgery at times as well. So is a vaccine made with the tissue taken during the initial biopsy? So before chemo or after Whipple surgery when the tumor is removed? And if it is the later, what if there are no cancer cells left as the chemo has been so successful? So I think there are two different approaches to vaccines, similarly to immunotherapy and T-cell therapies. One is to develop it for each individual, meaning that we need the cancer tissue, we need enough leftover tissue, they have to evaluate it, they have to find antigens or proteins that are in the cancer cell but not in your normal cells, and try to come up with a personalized vaccine. It has been done as part of a trial. It's an mRNA vaccine that has been done. The bad thing about it is that it takes time, and also we might not always have that. So it's available with its own shortcomings. The alternative is the peptide vaccine, as long as we have had a biopsy of tumor somehow, sometime, even before chemo, before radiation, before surgery. And as long as we know certain KRAS mutation is present in the tumor, that vaccine study can be used. This is off the shelf, meaning that they don't have to spend time to make it for you. They're already available, and it's just a matter of utilizing it. This is the vaccine study that we have. This is a peptide vaccine. So these are different approaches, and I would say that hopefully we will have both approaches available, but they're still in the clinical trial phase with some initial promise, but none of them are at the stage that they are approved and they can be used outside of context of trials. Statistic is changing on age, getting any type of cancer. Why after Whipple surgery have lots of digestive and intestinal issues? So for sure, the statistics is changing. I think a lot of cancers were and are developing with advanced age because as you live longer, the number of times that your old cells have to give birth to new cells and make new DNA increases. So by saying that the chances that one of these mutations can happen or some of this division can go wrong is higher. And also you're exposed to more things in your life. You know, you're exposed to more chemical, to more radiation or such. So one of the reasons was that it was happening mostly in the elderly. Why is it happening in earlier age group? We are not sure, probably a combination of many different things, exposures, diet, additives, a lot of things that we might not know completely about. But there is a shift a bit, like the classical pancreatic cancer is happening, but there's also a shift of people happening it earlier in their 40s or such, way before we would see it previously, even in the absence of hereditary conditions. And there's a lot of research going on. I would say the promising research is in trying to use means of preventing cancer from happening. And I would see that if the vaccine study shows promise in the post-surgical setting, it's possible that they can also use it in the prevention setting. So I think that is an area that will hopefully advance over time. Why after surgery? I have lots. So the reality of Whipple surgery is that you have portions of your small intestine, portions of your pancreas, portions of your bile system taken out and reconnected. So in a way, it's a completely different plumbing system that happens. And sometimes when the cancer cells are invading the nerves, your surgeon might have to cut a lot of nerves out in order not to leave anything behind. And those nerves are the ones that control your bowel movements, meaning that if they're taken out, many patients can have diarrhea post-surgery. Or sometimes people can get pancreas insufficiency. You're not having enough enzyme post-surgery. So it's common to have some issues with the digestive system post-surgery. The extent of it depends on how much of pancreas is taken out, how much of nerves are taken out. But mostly people learn to develop a new normal. You know, they understand what is the baseline now, and they try to make sure that, you know, that's something that they can go on with their normal life despite those new issues that they have post-surgery. Should enlarged lymph nodes in pancreatic survivorship be removed or watched? If you're talking about when we are monitoring the tumor, meaning that we are doing serial imaging, I would say if it becomes to a level that you're concerned that there might be cancer in it, for sure we do something about it. That includes getting a biopsy, and if it is there, depending on timeline and depending on location, sometimes they can be radiated, sometimes rarely they can be taken out with surgery. So to answer that, yes, I mean, ideally something should be done, but sometimes if they're very in the indeterminate setting, meaning that they don't know what it is, maybe inflammation post-surgery, maybe vaccine has caused that, you've got COVID vaccine and lymph nodes, or there might be watched by serial imaging and then acted upon if they're still looking like they're not going away. Is it true we are born with cancer cells? It is possible. As we discussed, it's possible that we make cancer cells every day. But again, it's like your cell have means of killing those, like either internal mechanisms like spell checkers or such, or your immune system can really detect the cancer cells and eradicate them. However, why is it that some people develop cancer and some people don't in their lifetime? I think that is something that we don't know exactly why. So again, the answer is that probably, but I'm not sure. So I don't know if there is any other questions. So I want to thank you everybody for, I know it's like your evening, for taking time, participating in the lectures. And just to summarize everything, I really truly believe that the best way to make the outcomes better would be to just try to participate in clinical trials. So, sorry, I think there was one more. Can one tumor have a mutation, for example, BRAF, but not another tumor? If you're talking about patient to patient, for sure. If you're talking about in a same person, one cancer cell having one mutation and one other not having it, it is possible. And I think that's why the new technologies are looking at one cell sequencing, meaning that they're looking at one cancer cells doing DNA, RNA, looking at another cancer cell doing DNA, RNA. So that is a newer way, and that is what will help us if we are using targeted therapies to understand how the tumor is evolving and why is it becoming resistant to some treatments. In the same person, yes, it is possible. Protect Panc. So, Melissa, is there a way to share the contact numbers for our trials, including Protect Panc?
Yes, I can drop it into the chat.
Yeah, so for sure you can reach out and then we can evaluate and see if you're a candidate for that. I think then we would be able to help you with that.
Let's grab it up really quick.
Does your facility have clinical trials for people with KRAS G12V? We do. Part of it is the iPredict study. Also, University of Madison has a T-cell therapy for KRAS G12V, but you have to have a certain immune makeup, HLA. That is the HLA A1101. But yes, the short answer is yes. The other thing is that the KRAS study, the Revolution Medicine drug, the anti-KRAS, is a pan-RAS inhibitor, including KRAS G12V. So there are already trials available. We are opening one of them in later line, as other than the one that I discussed. But there are already potential trials available nationally that would have KRAS inhibitors that can also be used for KRAS G12V. Do we have recording of this, Melissa?
Yes, a recording of this will be uploaded towards the end of the month.
And also, I think Melissa can help you to get to get on list of trials. Yeah, I think if you, Melissa will share you the link. If you go there, there are always contact numbers. You can reach out and then we can evaluate you for trials and then we can help you to go on that here. If there are trials elsewhere, my suggestion is to discuss it with your oncologist and they can help you figure out how to go on the list of trials outside of where you're getting treatment. Okay, I think I answered any question. Did I miss anything, Melissa?
Oh, looks like one more maybe just popped up.
In pan-KRAS trial, a contraindication of KRAS vaccine. For the vaccine one, there's no contraindication. There are two major, we call it exclusion criteria. One is that if there is low lymphocyte count post-surgery, the trial excludes patients because they think there might not be enough lymphocytes because the lymphocytes, the T cells are the ones that are used to fight the cancer. You need that to be able to have the benefit of vaccine. The other is that there's a certain KRAS Q61, H or R or such that is not included as part of the vaccine. So it will be certain type of mutation, which is majority of mutation. I would say 90% of mutations in KRAS mutation in pancreatic cancer are not that other subset. And also, again, mostly just not having a metastatic disease, meaning that for the vaccine study, they don't want visible cancer. So this is truly a post-surgery without metastasis setting. Okay. So unless anybody has questions, I think we can finish this. Again, thank you all for connecting.
Thank you
Take
so
care.
much.